Thank you. You've given me a difficult task to speak to this audience after lunch. So if people want to yawn, please yawn. I will not mind it. So I'm Sweta Mangal. Like she said, I founded an ambulance company prior to what I'm doing now. So I want to start by telling you why we started an ambulance company. Way back in 2003, my best friend, Shafi Mehta, his mother choked in her sleep at midnight in Cochin, Kerala. He did not know what to do. He did not know which number to dial. He did not know which hospital to take her to. He drove his mom in the car to a hospital where she was in the ICU for 3 days fighting for her life. This incident shook him as an individual. He thought to himself, when educated people like him do not know what to do in an emergency, just think about the poor people in India. That was the start of starting an ambulance company in Mumbai way back in 2003. We started with 2 ambulances. We didn't know why nobody had thought about starting an ambulance service in India. We were educated abroad. We knew how 911 worked. We knew how 999 worked. But in India, the number which we were given is 102. And you wouldn't believe the initial research which we did in the city of Mumbai, we found that there were 1,400 registered ambulances in Mumbai alone. But the sad thing was that only 100 were put to life-saving use. The remaining were used as hearse ambulances. Do you know why? Do you know why most of the people run their ambulances as hearse ambulances? Because it's a very profitable business. You don't need any equipments, you don't need trained manpower. All you need is an ambulance with a stretcher and an ice box, and that's it. And you make lots of money. So as a result, in 2004, when we started these 2 ambulances in Mumbai as a research, what we found was that people did not trust in calling an ambulance. Because when you dialed 102, at least in Mumbai at that time, it actually connected you to a crematorium, thinking that you're calling for an ambulance for someone who's already dead, not for someone who's alive. And that was the reality. With this in mind, we started a company. We called it Zikitsa Healthcare. It's a tongue twister, but it has a meaning to it. Zikitsa stands for Chikitsa, which you all know what it means, and Jigyasa. Because we were young people trying to solve this problem of emergency care, we called it Zikitsa. In 2007, we started with 10 ambulances under the number 1298. Why the number 1298? We'll have a separate session on that. But the whole idea was to provide good quality ambulance services to people in the city of Mumbai. We decided we will not run it as an NGO. The reason being, we said we do not want to just keep begging for money to run a service which is so essential to a life. And therefore, we started it as a social enterprise. The model which evolved was very simple. We said that we cannot make out whether a person is poor or rich when the person is getting onto the ambulance, right? It's about the destination which will define whether the person can afford the service or whether the person cannot afford the service. So in the city of Mumbai, we decided if a person is going to a Leelavati or to a Hinduja, he would have to pay 1,000 rupees for the ambulance service. But if a person is choosing to go to a KEM or to a Sion hospital, the same service will be made available to the person at 500 rupees. So this came to be known as the cross-subsidy model. And in 3 months, we broke even on this model. With that, we scaled up to 100 ambulances in the next 3 years with investments from social funds like Acumen Fund and other funds in the US. NRHM was formed in 2005. They decided to run ambulance services in India under public-private partnership. We started to work with the government. Well, I agree, like our previous speaker said, that's one thing I would change in my life, working with the government. But the reality is, if you want to serve the poor in India, that is a reality. You have to work with them. So just to give you today where we are after 13 years, We now have 1,500 ambulances operating across India. We have three models. One, what we call is like the taxi model, the 1298 model. When a person calls for the ambulance, the closest ambulance goes and the person pays after the service is given. It's a standard rate card which we have. The second is we work with the government. So the popular service 108, we now operate across 5 states with the government. Also now we are the leading provider for ambulance services to private hospitals. A lot of hospitals like Max, Fortis, Narayan, Hudale, they all outsource the ambulance services to us. So that has been the success of Zikitsa so far. However, 2 years back, Shafi and myself, we stepped back and we asked ourselves a question. Is this enough? Is what we've done in Zikitsa enough to solve the emergency crisis in the world? And the answer was an emphatic no. You know why? Because more people die from lack of timely medical care than from AIDS, malaria and TB. This is a statistics from WHO. People talk about AIDS, people talk about malaria, people talk about TB, but nobody talks about lack of timely care. That is the reality. Even more, look at this. 6.25 billion people living in developing countries do not have access to reliable medical care. Unlike the US, which has 911, or a UK, which has 999, or a Europe, which has 112. Creating an ambulance infrastructure. In India, it's taken us 10 years to have 1,500 ambulances on road. It will take a long time before developing countries can have a service which is as efficient as 911. Can we solve this? Can we do something in the interim? That is the question. Developed countries, yes. Emergency care, the problem is solved, but the problem lies in non-emergency, wherein the average wait time is 4.5 hours and it's very expensive to get treated in the developed countries. So what is the solution? Now, one thing, we are not doctors. We are business people, we are entrepreneurs who look at a problem and think of a solution. We said, when a car problem, a taxi problem can be solved by an Ola or Uber, can you not look at aggregating medical resources and solve this problem of emergency care? And what came out is this. The solution which we've actually launched as a pilot is aggregating doctors, nurses, EMTs, paramedics, validating them, training them, and making them available at a single touch of a mobile phone to a patient so that the closest medical personnel can physically come to the patient in less than 10 minutes and help the person at least stabilize till the next response, which could be an ambulance service or a senior specialist coming or you going to them, can be resolved. It's a very simple solution. Aggregating medical resources, validating them, making them available on a cloud platform, and to a patient making them available at a single touch of a button. Why this can be a reality? 80% of the world population will have smartphones by 2020. This will change the way people live. It's already changed in India, right? And it's changing worldwide. So the concept is very simple. It's a mobile app. It's called MUrgency. And what it does, if you press that button, we've just launched the pilot in the city of Chandigarh on 16th Feb. We have 368 responders in that small city of Chandigarh who are available to help people in their vicinity. All you need to do is touch that button, and like Ola, Uber, you see the people who are around your area in 5 kilometers, and if you press that button, a person will come to you in less than 10 minutes. We have done this for 1 month and it's working. However, one thing which we realize that it's an app, it needs to be on your phone. Emergencies won't happen every day, right? Why would you then keep an app on your phone wherein you may use it once in your lifetime? But it's important that you have it on the phone because once in that lifetime could be your life and death situation. So therefore what we've built in is other features which will ensure engagement. So we have a feature called Ask Doc, wherein you can ask any question to a doctor and within 15 minutes, somebody will guide you. It's not prescribe any medicines, only guidance. Also, we have a medical concierge service, like you have doctor appointments, you could do a home visit for doctor, nurses, because we already have the network in place. When we started working on this concept a year back, and we started to work in Chandigarh, we thought we would individually go to doctors and nurses and sign them up and convince them to be available. And to our surprise, what we found, that the hospitals were very willing to come on the network. For them, they already had the emergency room, they already had the emergency staff, they already had the ambulances. All they needed to know is where the emergency is happening so that they could send out their team to get the person. So now, today, we have Fortis, Max, Mayo, Inscall, all the top hospitals and the second tier hospitals with us on our platform in the city of Chandigarh. The business model is very simple. 80% of each transaction goes to the responder or to the institution who has sent the resource out, and 20% gets retained by the emergency platform. So this idea is global. We do not dream of doing this only in India. India is our starting point, is a pilot market, but we are very clear this has to be a solution for the developing countries, because this problem is in India, is in Bangladesh, is in Sri Lanka, is in Africa. So we are building this platform for a global response. And to build a platform like this, and if you want to be globally available, one way is to work with the governments. Working in Zikitsa for 10 years, working with the government, I think I've done my job enough. And therefore, we said we're going to work with world leaders and global agencies to get this platform going. We have not put it on record, but Red Cross, we have signed up Red Cross. 1.7 million people who are trained on first aid and CPR are available across the world who are willing to serve people, but they do not know where emergencies are happening. They don't even have a platform to communicate with each other. They are going to come on board, and therefore this platform will become very useful. Of course, when you're doing something global, big, you need big people behind you, and you need guidance. Harvard, Stanford, MIT, all three have adopted us as a good idea and are supporting us through their professors and their students. The biggest one has been the support and the investment from the top 5 ambulance companies in the world. And I'll tell you why this is important. When you're trying to have responders across the globe in the developing markets and the developed market, these resources, so a FALC, for example, has 1 lakh paramedics working with them. You go to a market, they already are on your platform because they've done the seed investment. A Zikitsa Healthcare, which is what we formed in India, has 6,000 employees, which are paramedics. So they are already on your platform. So these partnerships will also help us grow faster globally. The team, we have 65 people working with us and now 25 full-time people. Of course, we started with a dream with no money, but now the support is coming in. We've now raised some money so that we can do a pilot in India, and if it's successful, take it forward globally. The traction has been great. Like I said, we just launched on 16th Feb in the city of Chandigarh to test the idea. Now, people ask me why Punjab and Chandigarh. Punjab has the highest, one of the highest penetration of smartphones. You know, it's Punjabis, right? So they love to show off. Highest penetration of smartphone. They are open to new ideas because one in their family is either in Canada or in Birmingham. So they're very open to new ideas. We have an experience of running 240 ambulances there with the government for the last 5 years. And we didn't want to pilot this idea in a big metro because a small mistake in a big metro can cause you big damage. And therefore we chose Punjab as the pilot. The entire Punjab will be launched by May end of this year. So we've right now launched only the Tri-City area with 368 responders, 36 hospitals. And now we are looking at 25 transactions a day, and we've got around 3,000 downloads in a month. All these hospitals on our board. And yes, we are here to save people in their most important time in an emergency and provide that one step of help where a person comes and gets them, stabilizes them till the rest of the process follows. Thank you.
Brilliant concept. Congratulations on bringing it to India. Thank you very much for that. So we now know where we ought to go when we have an emergency. We don't want to have one, but if we have one. Question was, your primary reach would be through the app only, or would it also supplement a telephone number, like, or would you become the new 911 for India then?
No. See, one thing is we are not competing with ambulance services. We are only complementing them. We are saying today an average response of a 108 or a 1298 in an urban setting is 20 to 30 minutes. In a rural setting is 40 to 50 minutes. So is there a way where we can at least send a first responder to the patient while the ambulance response follows? And we are looking at the future clearly. See, the cost has to be low. So for example, in Chandigarh, we launched the service as 350 rupees. Only 350 rupees. Very affordable. So the minute you add a call center, this, that, the cost increases. So our, I know it will be a big task for us to market it and get people to use it through the app, but I think that's the way to go.
Time for one more question.
Presentation. I would just like to point out that when you look at the international benchmarks for emergency medical services, this is the primary segment, just the response time. Our biggest challenge in the healthcare industry is the quality of people inside the ambulance and what can be delivered at the doorstep and on the way. And this is a classic case. You have a fantastic model, but this is the case of the turbo engine to the bullock cart. You have a fantastic ambulance, but you have roads which will take you 2 hours to reach from point A to point B. And there are so many other issues. This is a fabulous initiative. I think you should also look at what I was saying in the morning. If you do decide to add value, the biggest difference between ambulance services in India and abroad is the quality of medical care which is given inside the ambulance and at the point of care. That is something you should look at. It may not be, you're not entrepreneur, because that is what benchmarks those services vis-a-vis our services. The response time is just one indicator. Actually, the quality indicators are all sitting elsewhere. Since you've got this platform, you may look at how to scale up in terms of value adding to just the response time. Something you should think about, and there's a huge market out for that if you look at the business model.
Yeah. So I just want to add to one thing. One is it's not an ambulance response which will get to you in 10 minutes. Maybe I didn't specify that right. We are aggregating medical resources as in doctors, nurses, paramedics, EMTs, who are already working with hospitals or institutes and training them again. We have our own training institute, so we are doing BLS, first aid, CPR with them, which they have to clear. There's a test which is a theory and a practical test. So you are assuring that a person who goes physically on the bike, they could be on their bike, they could be in their car. The point is to get to the person. See, in our experience of 10 years, what we have seen is by the time an ambulance reaches the person, it's 30 minutes. It's too late, So can you at least stabilize the person while the ambulance response is on the way? And I agree with you, quality is key. And we have to make sure that if you're trying to create this as a global platform, we need to be very cautious about quality. So, that goes without saying.
You need to put out quality indicators.
Yes.
As they say, in God we trust, but all others, data.
Point taken. Okay.
All right. May I request?
Dr. Markov from Bhagavan Mangal Hospital. It's an excellent initiative. I just want to know from your experience when you approach these doctors and when you approach these hospitals to get a panel with you, has anyone ever questioned you or has anyone been reluctant to say that we want to know whether it's a medico-legal case and whether, what is the medico-legal aspects and implications, And if so, we don't want to be involved with those type of cases, but we'll be involved with other cases. I mean, if you come across this.
So obviously legal liabilities are a big question when we go for the enrollment of hospitals or individuals. So see, today, for example, I'll take an example. You call Max Hospital. You know, say I have an emergency at home. What would they do? They will send an ambulance to you to get you, right? So they are anyways taking on that liability and they're already doing that job. Yeah, so I'm coming to that. So for hospitals, I think that is the thing. They already, in any case, they are going to emergencies and so, you know, going and attending them and bringing them to the hospital or solving them there, whatever the case may be. Now, in case of an individual, the way we've told the individual is, the first thing is, and that works in our 108 ambulance service call center, the first thing you do is call the patient back and understand from the relative or the patient if he's in a situation to talk what has happened, right? After only knowing the whole situation is when you go for the call. And if you feel that it's a medico-legal case or whether somebody shot somebody and you need the police, obviously those are the ones you need to escalate to the police, etc. So we have a separate process for that. So it's about a responder figuring out whether he is apt to go for that case or not. And you are giving that flexibility to a responder to call the person and figure out what has happened. Except in accident cases, right? But you know, when we think of a solution, we always get stuck with accident cases. The reality is, out of the 100% of emergency cases, accident cases are what, 2%, 3%? The rest, no, I'm telling you 108 data. It's 2 or 3%. The rest are emergencies which happen at home, whereas somebody is with you to kind of explain what's happened.
Right. Thank you, Sweta. And
And there's a
Sweta will be
question
with us, so can we take the questions later?
Okay, fine.
So she'll be here during tea break if you can take the questions. We're running a little bit behind schedule. May I please request Mr. Basur Shetty from Red Cross to hand over a small memento to Sweta?
Yes.